Liver. Liver is a large and solid gland situated in the right upper quadrant of the abdominal cavity. In the living subject, the liver is reddish brown in color, soft in consistency, very friable. It weighs about 1600 grams in male and about 1300 grams in female. Location: the liver occupies the whole of the right hypochondrium, the greater part of the epigastrium, and extends into the left hypochondrium, reaching up to the left lateral line. From the above, it will be obvious that most of the liver is covered by ribs and costal cartilages, except in the upper part of the epigastrium, where it is in contact with the another abdominal wall. The liver is the largest gland in the body. It secretes bile and performs various other metabolic functions. The liver is also called hepar, from which we have the adjective hepatic, applied to many structures connected with the organ. External features: the liver is wedge shaped. It resembles a four-sided pyramid laid on one side. This is the left hypochondrium and epigastrium. This is the liver. Superior layer of the coronary ligament, left triangular ligament, left lobe, falciform ligament, ligamentum teres, the fundus of gallbladder, inferior border, right lobe. Surfaces: it has 5 surfaces. These are anterior, posterior, superior, inferior, right. Out of these, the inferior surface is well defined because it is demarcated anteriorly by a sharp inferior border. The other surfaces are more or less continuous with each other and are imperfectly separated from the one another by ill-defined rounded borders. Prominent border: the inferior border is sharp and anteriorly where it separates the anterior surface from the inferior surface. It is somewhat surrounded laterally where it separates the right surface from the inferior surface. The sharp anterior part is marked by an interlobar notch or the notch for the ligamentum teres, a cystic notch for the fundus of gallbladder. In the epigastrium, the inferior border extends from the left 8th costal cartilage to the right 9th costal cartilage. Liver is lobes of the liver. The liver is divided into right and left lobes by the attachment of the falciform ligament anteriorly and superiorly, by the fissure for the ligamentum teres inferiorly, and by the fissure for the ligamentum venosum posteriorly. Falciform ligament, ligamentum teres, and inferior border. Ligamentum, superior layer of coronary ligament, left triangular ligament, left lobe, falciform ligament, ligamentum teres, the fundus of gallbladder. These are the inferior border, and this is right lobe. The right lobe is much larger than the left lobe and forms 5/6 of the liver. It contributes to all the 5 surfaces of the liver and presents the caudate and quadrate lobes. The caudate lobe is situated on the posterior surface and is bounded on the right side by the groove for the inferior vena cava, on the left by the fissure for ligamentum venosum, and inferiorly by the porta hepatis. Above, it is continuous with the superior surface. Below and to the right, just behind the porta hepatis, it is connected to the right lobe of the liver by the caudate process. Below and to the left, it presents a small rounded elevation called papillary process. The quadrate lobe is situated on the inferior surface and is rectangular in shape. It is bounded anteriorly by inferior border, posteriorly by porta hepatis, On the right by the fossa for the gallbladder, and on the left by the fissure for the ligamentum teres. The porta hepatis is a deep transverse fissure about 5 centimeter long, situated on the inferior surface of the right lobe of the liver. It lies between the caudate lobe above and the quadrate lobe below and in front. The portal vein, the hepatic artery, hepatic plexus of nerves enter the liver through the porta hepatis, while the right and left hepatic ducts and a few lymphatics leave it. The relations within the porta hepatis are from behind forwards are the portal vein, the hepatic artery, and the hepatic ducts. The lips of the porta hepatis provide attachment to the lesser omentum. The left lobe of the liver is much smaller than the right lobe and forms only 1/6 of the liver. It is flattened from the above downwards near the fissure for the ligamentum venosum. Its inferior surface presents a rounded elevation called omental tuberosity or tuber omentale. Relations, peritoneal relations. Most of the liver is covered by peritoneum. The areas not covered by peritoneum are as follows. A triangular bare area on the posterior surface of the right lobe, limited by the superior and inferior layers of the coronary ligament and by the right triangular ligament. The groove for the inferior vena cava on the posterior surface of the right lobe of the liver between the caudate lobe and the bare area. The fossa for the gallbladder, which lies on the inferior surface of the right lobe to the right of the quadrate lobe. The area of attachment of lesser omentum and the fissure for attachment of ligamentum venosum. Visceral relations. Anterior surface. The anterior surface is triangular and slightly convex. It is related to the xiphoid process and to the anterior abdominal wall in the median plane and to diaphragm on each side. The diaphragm separates this surface from the pleura above the level of a line drawn from the xiphisternal joint to the 10th rib in the mid-axillary line, and from the lung above the level of line from the same joint to the 8th rib. The falciform ligament is attached to the surface a little to the right of the median plane. Posterior surface. The posterior surface is triangular. It is middle part shows a deep concavity for the vertebral column. Other relations are as follows. The bare area related to the diaphragm and to the right suprarenal gland and near the lower end of the groove for the inferior vena cava. The groove for the inferior vena cava lodges the upper part of the vessel and its floor is pierced by the hepatic vein. The caudate lobe lies in the superior recess of the lesser sac. It is related to the crura of the diaphragm above the aortic opening, to the right inferior phrenic artery, and to the celiac trunk. The fissure for the ligamentum venosum is a very deep and extends to the front of the caudate lobe. It contains two layers of the lesser omentum. The ligamentum venosum lies on its floor. The ligamentum venosum is remnant of the ductus venosus of the fetal life. It is connected below the to the left branch of the portal vein and above to the inferior vena cava. The posterior surface of the left lobe is marked by the esophageal impression. Superior surface. The superior surface is quadrilateral and shows a concavity in the middle. This is the cardiac impression. On each side of the impression, the surface is convex to fit the dome of the diaphragm. The diaphragm separates the surface from the pericardium and the heart in the middle, and from pleura and on lung on each side. Inferior surface. Inferior surface is quadrilateral and is directed downward, backward, and to the left. It is marked by impressions for neighboring viscera as follows. On the inferior surface of the left lobe, there is a large concave gastric impression. The left lobe also bears a raised area that comes in contact with the lesser omentum, and it is called the tuber omentale. The fissure for the ligamentum teres passes from the inferior border to the left end of the porta hepatis. The ligamentum teres represents the obliterated left umbilical vein. The quadrate lobe is related to the lesser omentum and the pylorus and the first part of the duodenum. When the stomach is empty, the quadrate lobe is related to the first part of the duodenum and to a part of the transverse colon. The fossa for the gallbladder lies to the right of the quadrate lobe. To the right of this fossa, the inferior surface of the right lobe bear colic impression for the hepatic flexure of the colon. The renal impression for the right kidney and the duodenal impression for the second part of the duodenum. The right surface is quadrilateral and convex. It is related to the diaphragm opposite to the 7th to 11th ribs and in the mid-axillary line. It is separated by diaphragm from the pleura up to the 10th rib and from the lung up to the 8th rib. Thus, the upper one-third of the surface is related to the diaphragm and the pleura and the lung, the middle one-third to the diaphragm and the costodiaphragmatic recess of the pleura and the lower one-third to the diaphragm alone. Arterial supply, the liver receives 20% of its blood supply through the hepatic artery, 80% through the portal vein. Before entering the liver, both the hepatic artery and the portal vein divide into right and left branches. Within the liver, they redivide to form segmental vessels, which further divide to form interlobular vessels, which run in the portal canals. Further ramifications of the interlobular branches open into the hepatic sinusoid. Thus, the hepatic arterial blood mixes with the portal venous blood in the sinusoid. There are no anastomosis between adjoining hepatic arterial territories and hence each branch is an end artery. In venous drainage, hepatic sinusoids drain into interlobular veins which join to form sublobular veins. These in turn unite to form the hepatic vein which drain directly into the inferior vena cava. These veins provide great support to the liver besides the intra-abdominal pressure. The hepatic veins are arranged in two groups, upper and lower. Upper group consists of three large veins, right, left and middle, which emerge through the upper part of the groove for the inferior vena cava and open directly into the vena cava. These veins keep the liver suspended. The lower group consists of a variable number of small veins from the right lobe and the caudate lobe which emerge through the lower part of the caval groove and open into the vena cava. Microscopically, the tributaries of hepatic vein, central veins are seen as separate channels from those of the portal radicals. Lymphatic drainage. The superficial lymphatics of the liver runs on the surface of the organ beneath the peritoneum and terminate in caval, hepatic, pericardial, and celiac lymph nodes. Some vessels from the coronary ligament may directly join the thoracic duct. The deep lymphatics and partly in the nodes around the end of the inferior vena cava and partly in the hepatic nodes. Nerve supply. The liver receives its nerve supply from the hepatic plexus which contain both sympathetic and parasympathetic or vagal fibers. Nerves also reach the liver through its various peritoneal ligaments. Hepatic segments nerves also reach the liver through its various peritoneal ligaments. Hepatic segments on the basis of the intrahepatic distribution of the hepatic artery, the portal vein, and the biliary ducts, the liver can be divided into the right and left functional lobes. These do not correspond to the anatomical lobes of the liver. The physiological lobes are separated by a plane passing on the anterior-superior surface along a line joining the cystic notch to the groove for the inferior vena cava. On the inferior surface, the plane passes through the fossa for the gallbladder, and on the posterior surface, it passes through the middle of the caudate lobe. The right lobe is subdivided into anterior and posterior segments, and the left lobe into medial and lateral segments. Thus, there are 4 segments in the liver. So, the segments of the liver 1, 2, 3, 4, 5, 6, 7, 8. Right anterior 5 and 8. Right anterior is 5 and 8. Right anterior. Right posterior 6 and 7. 6 and 7 called right posterior. Left lateral 2 and 3. 2 and 3 called left lateral. 2 and 3 left lateral. Left medial 1 and 4. 1 and 4 are called left medial. So this is the left and right lobes. And in that right anterior, 5 and 8 are right anterior. 5 and 8. Right posterior, 6 and 7. Right posterior, 6 and 7. Left lateral, 2 and 3. Left lateral, 2 and 3. Left medial, 1 and 4. Left medial, 1 and 4. The hepatic segments are surgical importance. The hepatic veins tend to be intersegmental in their course. Functions: liver is an indispensable gland of the body. Metabolism of carbohydrates, fats, proteins, synthesis of bile and prothrombin, excretion of drugs, toxins, poisons, cholesterol, bile pigments, and heavy metals. Protective by conjugation, destruction, phagocytosis, antibody formation and excretion, storage of glycogen, iron, fat, vitamin A and D. Dissection: pull the liver downwards and divide the anterior layers of the coronary and left triangular ligaments. Identify the inferior vena cava between the liver and the diaphragm and separate the liver downwards from the inferior vena cava. If the inferior vena cava happens to be deeply buried in the liver, divide it and remove a segment with the liver. Expose the structures in the porta hepatis and follow them to their entry into the liver. Identify the viscera related to the inferior surface of the liver and see the demarcations on the liver. Explore the extent of the right and left pleural cavities and pericardium related to the superior and anterior surfaces of liver, though separated from it by the diaphragm. Cut the structures close to the porta hepatis and separate all the peritoneal ligaments and folds of the liver. Remove the liver from the body, identify its various borders, surfaces and lobes. Clinical anatomy: if the infrasternal angle, the liver is readily accessible to the examination and a percussion, though it is normally not palpable due to the normal tone of the recti muscles and the softness of the liver. Normally, in the median plane, the inferior border of the liver lies on the transpyloric plane about a hand's breadth below the xiphisternal joint. In women and children, this border usually lies at a slightly lower level and tends to project downwards for a short distance below the right costal margin. It enlarges towards the right iliac fossa. Spleen also enlarges towards the right iliac fossa. Inflammation of the liver is referred to as hepatitis. It may be infective hepatitis or amoebic hepatitis. Under certain conditions, the malnutrition, liver tissue undergoes fibrosis and shrinks. This is called cirrhosis of the liver. Liver biopsy needs to be done in certain clinical conditions. Liver biopsy needle is passed through the right ninth intercostal space. Liver biopsy needle passed through right ninth intercostal space. It traverses both pleural and peritoneal cavities. Liver is the common site of metastatic tumors. Venous blood from GIT, gastrointestinal tract, with primary tumor drains via portal vein into the liver. Liver receive blood from hepatic artery and portal vein. Both these vessels lie in the free margin of the lesser omentum. Bleeding from the liver can be stopped by compressing the free edge of lesser omentum. This is called Pringle maneuver. If bleeding still continues, it is likely that inferior vena cava is also injured. Liver resection. Liver resection for primary and secondary tumors is done commonly. 80% of liver mass can be removed safely. Liver can regrow to its original size within 6 to 12 months after resection. Major resections follow the planes between the segments and are anatomical. Liver transplantation. It can be done in patients with the end stage liver disease. The implant of the graft require an inferior cabal anastomosis followed by anastomosis of the portal vein. Finally, the arterial and biliary anastomosis are performed. Sometimes right hemiliver comprising segments 5 to 8 can be removed from the healthy donor and transplanted into the needy patient. The clinical anatomy in the infrasternal angle, the liver is readily accessible to examination and percussion, though it is normally not palpable due to the normal tone of the recti muscles of the softness of the liver. Normally in the median plane, the inferior border of the liver lies on the transpyloric plane about a hand's breadth below the xiphisternal joint. Transjugular intraparenchymal portosystemic shunt for portal hypertension. In severe portal hypertension, balloon catheters are introduced from internal jugular vein into the superior vena cava, into the inferior vena cava, hepatic vein, liver tissue, portal vein branch. This is the order. Liver cirrhosis causes caput medusae at the umbilicus. Histology. Liver is covered by Glissen's capsule. In the pig, there are hexagonal lobules with portal radicals at 3 to 5 corners. Each radical contains bile ductule branch each of the portal vein and hepatic artery. Central vein lies in the center and all around the central vein are the hepatocytes in form of laminae. On one side of the lamina is the sinusoid and other side is the bile canaliculus. Portal lobule seen in human is triangular in shape with 3 central veins at the sides and portal tract in the center. Liver acinus is defined as the liver parenchyma around pre-terminal branch of the hepatic arteriole between two adjacent central veins. The liver acinus is a functional unit of liver. Blood reaches the acinus via branches of the portal vein and the hepatic artery to open into the sinusoids to reach the central vein. On the other hand, the flow of bile is along bile canaliculi, bile ductules, and the interlobular bile ducts. Hepatocytes in zone 1 close to the pre-terminal branch are better supplied by oxygen, nutrients, toxins. The liver cells in zone 3 close to central veins are relatively hypoxic, while cells in zone 2 are intermediate in oxygen supply. Histology of the liver can be studied by liver biopsy, which is done from the right lateral surface. Histology of liver. From the caudal end, development from the caudal end of foregut, an endodermal hepatic bud arises during third week of development. The bud elongates cranially. It gives rise to a small bud on its right side. This is called pars cystica, and the main part is pars hepatica. Pars cystica forms the gallbladder and the cystic duct, which drains into common hepatic duct. Epithelial cells of the pars hepatica proliferate from the parenchyma. These cells mix up with umbilical and vitelline veins to form hepatic sinusoids. Coffer cells and blood cells are formed from the mesoderm of septum transversum. Molecular regulation, fibroblast growth factor 2 secreted by cardiac mesoderm interact with the prospective liver forming endoderm and induces formation of the hepatic diverticulum. BMPs secreted by septum transversum appear to enhance the competence of prospective liver endoderm to respond to FGF2. Hepatocyte nuclear transcription factors HNF3 and 4 partially regulate the differentiation of the prospective liver endoderm into hepatocytes and biliary cells lineages.